So today we're going to go through sections 1 through 5, and then we're going to go through 1 through 10 next week. So as I said, there's a lot of material out here that we need to go through. And again, bear with me on my technical difficulties over here. So as we mentioned, this course will provide you with an overview of the patient-centric revenue cycle model. I will share with you then when I started my career at Memorial Sloan Kettering a long time ago as a self-pay collector, no less, right? That was not an easy job. That processes were not consumer-centric per se. And at that time, just to age myself more than I normally do, our mantra was 90 days in 90. Yes, I did indeed start my career at the age of 12. So, but certainly things have changed dramatically, and a patient-centric revenue cycle was not something that we were dealing with. Certainly that's where we are now. When I meet new folks and they ask what I do, I explain it as we support the processes that get providers paid. If you think about a time that either you or your family member needed care, and you got an order, you scheduled your visit, you came in and got registered, and they asked for your estimated out of pocket. They billed your insurance, they billed you, and hopefully did not send you to collections. That is the revenue cycle. It includes all of the major processing steps required to process a patient account from the request for service through zero balance. So pre-service is clearly scheduling and pre-accessing processing. They set the stage for effective patient communication and data collection. During the pre-service segment will be completed and the information will move point to point. It is critical that providers optimize these steps to avoid downstream impact, such as denials, increased cost to collect, increased bad debt, and dissatisfied patients. Surprising patients with healthcare bills like we did years ago is not accepted anymore. Certainly things like price transparency and the No Surprises Billing Act is proof of that. In addition, though, we do disservice to our patients when we treat them clinically, but then financially bankrupt them with surprised billing. I gotta admit somebody. The healthcare consumer landscape is changing. Consumers want to be known and understood in order to get a personalized healthcare experience. Therefore, understanding consumer attitudes and preferences across their healthcare journey is key for not only improving the experience, but also for supporting healthy behaviors, achieving better outcomes, and remaining competitive. So again, to walk through it, pre-service, scheduling and pre-registration, screening for medical necessity, healthcare plan coverage and benefits are verified, pre-authorizations are obtained. Estimates are created to inform the patient in advance of the service, their cost, which will include a deductible, co-insurance, or co-payment amount. This should be done prior to service to help the patient make informed decisions, not be surprised by bills, and get assistance with payment as needed. When I was running my revenue cycle, many times patients, particularly in surgical centers, are told to keep their personal items at home, which includes their wallet. So no ability to collect that time of service. And again, if not medically necessary, their personal items, staff should reach out to see if additional diagnoses are available to support coverage or present the patient an ABN or a notice of non-coverage. Technical difficulties. So time of service. Ideally, the scheduled patient has been pre-registered and can go directly to the service unit versus waiting in a main registration area. Consents are signed, and if not collected pre-service, agreed upon payments are made. Positive patient identification is completed, and the patient is given an armband. Unscheduled patients or non-pre-registered will have to go through a comprehensive registration process. And I think, as we know, particularly those that are still on the front lines, certainly a lot of things like armbands and other processes changed due to COVID restrictions. So that was the way of the past. It certainly probably has changed rapidly in the last 2 years. Post-service. Post-service includes the account activities that occur after the patient is discharged until the account receives a zero balance, such as final coding of all services provided, preparation and submission of claims, payment processing, and balance billing and resolution. This process is so dependent on the actions that occurred pre-service and time of service, and providers should invest in optimizing processes and embracing technology that avoids rework and increases cost to collect on the back end. On the back end, patients want healthcare conversations and communications that are personable to them. No longer can we treat each patient the same, because they're not. Their economic situation is different. Some patients want statements, some patients want text statements, some patients want emails. So, we need to change that both in collection conversations and modalities of communication, right? They want more digital and multimodal channels of communication. So we have to embrace how consumerism is changing. So the key points as you go through section 1.1 is clearly understanding the 3 segments of the revenue cycle: pre-service, time of service, and post-service. And then exactly what's happening at each component of it and how important each component of it, particularly those in the patient access segment, impacts the bottom line. And I will tell you, and I don't say it lightly, when I was running my revenue cycle, I had people moving from patient access to patient financial services constantly, because they were the same section and they didn't have to deal with patients. They were dealing with bills, they were dealing with denials, right? Patient access has it hard, and they were constantly leaving because of that. I changed that dynamic, and I actually had my patient access folks at a higher level than my PFS staff, so I can keep the good folks and have them engage with my patients. So understanding, again, what component of it is, and then certainly how important it is in the component of getting paid is an important thing. So first question, again, is an example of what you would typically see, that we want you to see if you got the concept right. What happens during the post-service stage? Orders are entered, results are reported, charges are generated, diagnostic and procedural coding is initiated, the encounter record is generated, and the patient and guarantor information is obtained and are updated. Final coding of all services, prep of claims, payment processing, or the focus is on the patient's and his or for her financial care in advance of the clinical care provided. So just again, example, see if you can make the right choice. Again, this is a way, again, we typically have polling questions. We'll try to get that up and running for our next sessions. The answer probably is, again, post-service is the third and final major segment of the revenue cycle. This segment includes the account activities that occur after the patient is discharged and until the account reaches a zero balance. And that would be then the third answer. That would be the correct one. Okay. So now more than ever, people are asking about the price of healthcare. CMS price transparency demanded that we give them that. Don't think it went far enough, unfortunately, because it's not meaningful to an individual patient, but it was a step in the right direction. The No Surprises Billing Act, maybe state regulations demanding that you provide patients with estimates, but prior to service, some of them are even going so far as to say if you get the estimate wrong, you can't balance bill your patient. That's a lot of things change estimates, but certainly, it's an important thing. So patients are called on to make more decisions and pay more out-of-pocket costs for the services than ever before. They are looking for the information they need to find and pay for quality care. Healthcare Dollars and Cents aims to answer these questions, to help make sense of price and value in healthcare. These voluntary practices address the area where best practices are most urgently needed. focusing on financial discussions that take place in advance of healthcare services, at the time of service, in the ED, and in other care settings. They provide definitive guidance about when and where patient financial discussions should take place and who should participate and what the topic should be. First and foremost, it should respect patients' privacy. Of course, in the ED, no discussion should occur before a patient is screened and stabilized per EMTALA regulations. The provider-patient conversation should consist of the following: compassion, communication, written follow-up, compliance framework, and certainly refer to HFMA's adopter program. So again, certainly a hot topic that providers have been dealing with right now due to, again, the mandates that are out there. The need for transparent healthcare pricing has never been more important due to the needs to help consumers make smart, educated decisions about the care they receive. Clients or patients and providers that embraced this years ago did it for the right reasons, not because CMS demanded it, because they knew it was the right thing to do for their patients. And they also did it in a competitive way. Proof shows that if patients know a true cost, right? I have a set cost if I go to this provider. I don't know what my costs are going to be over here. I'm going to go to the provider that provides me with that price transparency in a simple way. So, but in order to provide a patient with information that is meaningful to them beyond the 300 shoppable services and the charges in a machine readable format, several factors must be included. The type of hospital service based on a CPT code or MSDRG code, total charges, contracts or fee schedules per health plan, real-time eligibility of patients' current out-of-pocket to make it meaningful to them. Recognizing the industry need for guidance concerning this topic, HFMA convened a task force to develop 2 documents, Price Transparency Report and a Consumer Guide to Healthcare Prices. Both documents can be found in the online course in the resources section. So feel free to read it. It's not going to be on the exam, I don't believe, but again, it's a nice read to get better accounted to what's going on in the industry. HFMA also created the Medical Debt Task Force that builds off of HFMA's patient-friendly billing work. Best practices include education. Communication must be clear, concise, correct, and patient-friendly. Establish policies and make sure they are followed internally. Be consistent. Coordinate to avoid duplicate contacts. Exercise good judgment. Timing. Start the clock when the first statement is set. Report and track both to credit bureaus if needed, and track all consumer complaints. So some good advice from HFMA, certainly from the membership. So key points as you go through healthcare dollars and cents is the various revenue cycle initiatives that HFMA is supporting. Certainly there are more things about no surprise billing, if that's something that you're interested in finding out more, that are also available, has not been updated in the online course. And then certainly the importance of a good educated patient and consumer conversations as you talk to patients about what their liability will be. So which items are not best practices? Educate patients, report to healthcare plans when patient account is transferred to collection agency, follow best practices for communication, exercise moderate judgment when communicating with patients about scheduled services, and then coordinate to avoid duplicate efforts. I'm really hoping everybody here gets this right. One, it would not be the right thing to do to report to healthcare plans when patient account is transferred to the collection agency. There's absolutely no reason for them to know if the patient did not pay their self-pay balance. 2, I would argue that's probably some compliance or HIPAA stuff that would be going on there if you did report that to them. So that would not be best practice as you walk through that. I do have actually a second question. So which option is not a main HFMA healthcare dollars and cents revenue cycle initiative? Patient financial communications, process compliance, medical account resolution, or price transparency? And the correct answer is process compliance. Okay. So when you get into online course 1.3, at the end of this course, you should be able to speak to three various bullets. Patients expect value for their healthcare dollars, including greater transparency of quality and price information. Patient satisfaction also means that patients understand the provider's payment expectations and terms. Okay. So HCAHPS, or Hospital Consumer Assessment of Healthcare Providers and Systems. There are more mnemonics in healthcare than anywhere else, I am certain of it. The objective of this initiative is to provide a standardized method for evaluating patients' perspective on hospital care. So for additional information, visit cms.gov and search for quality initiatives. Of the 27 questions that they have out there, only one question encompasses the entire patient experience, which is, would you recommend this hospital to your family and friends? Not very clear, right? If they're not going to recommend it, why? Was it the billing aspects of it? Was it the clinical care aspects of it? So very broad stroked. And so certainly something they absolutely have to address. And certainly there are other metrics and stuff that CMS will do, Press Ganey and other initiatives that really are trying to elicit the patient's feedback on their experience with the hospital, both clinical more, but also some financial experience, but very limited to be able to really impact change. So it is important to understand that revenue cycle team members are an important component of patient satisfaction. It is not just the clinical care. Patients can be very dissatisfied with their engagement with both a patient access person. Did I wait too long? Am I getting nasty collection letters and calls? So revenue cycle does have impact on patient satisfaction with the provider. It actually can ruin a good clinical experience with a very bad financial experience. So that's why it's important to go that extra mile by creating patient-friendly processes aimed at improving the overall patient experience. Implement processes that are patient-centric and efficient. Educate patients about insurance coverage. They really don't understand it and what their out-of-pocket is, and it can alleviate concerns and issues on the back end when they get a surprise bill that they weren't expecting. So we need to communicate financial information clearly, consistently, timely, hoping prior to time of service that they can have those, know what they're getting into. At least at time of service, we shouldn't be waiting to the back end to tell them how much they're going to owe us and how we can work with them to address that balance that they're going to owe us. So hard cost is the loss of future revenue. Great clinical care, as I mentioned, can be eroded based on both the experience in their front end and back end collection efforts. So when I first started at University of Maryland, a patient called me and they said that all they talk about at their parties is how bad their experience was with respect to both registration and billing. Now, I was a brand new director of revenue cycle, so it wasn't my doing. We were working on trying to create that. So my immediate response, I wanted to say, you should probably get new friends if that's all you talk about at parties, but I didn't. I held my tongue. I listened to his complaints, and we continue to work forward to make sure that that wasn't the reputation of our organization. So to improve quality and decrease back-end billing, insurance verification, pre-certification, and pre-authorization should be done prior to service. Over 40%, I think the number is almost closer now to almost 65% of the information on a claim is gathered by access services, which is why it is so important we do it right up front. Dealing with back-end denials and corrected claims and things like that only increases our cost to collect, erodes our patient financial experience, results in lost revenue or delays in cash. So staff should receive extensive training in the art of welcoming behavior. I know that I had my staff take a bunch of HFMA, not led, we took the courses, and our staff led, our directors and supervisors led, patient financial conversations, how to ask for money, why we should be asking for money, long ago before we were really doing that. So staff has a responsibility to efficiently and professionally gather all information necessary to support the patient intake process. It is important to recognize that there is significant organization cost if policies pertaining to communication, customer service, and quality assurance processes are not established. And legal issues can also arise. For example, if a patient is registered with the wrong master patient index or MPI, and the correct patient arrives in the ED and is allergic to penicillin and it is given to them, then that can have some very serious legal issues. And I know in the course there's lots more about identifying the MPI and stuff, so you'll hear a lot more about that and how important that is to our patients. So what is the objective of the HCAHPS initiative? Standardized method for evaluating patients. Trying to get my thing to close. Give you a second there. I let somebody into the waiting room. Okay. And the correct answer is 3, to conduct evaluations concerning patient's perspective on hospital care. I could almost argue, and you're going to find this, I just want to put this out there. You're going to get into some of these multi-question ones, and when you get through that, you choose it. When you go into the answer and you choose the wrong answer, it'll tell you why it's wrong. And sometimes it's just wording. Right, so I could sit here and argue, which I'm sure some of you are going there and say, well, it's to provide a standardized method for evaluating patients' perspective on hospital care. So we know we can throw out 2 and 4, and those are what we need to do to be able to get that perspective. But the questions out there, go through, if you choose an answer and you really think it's right, and certainly we can go back to HFMA National and say, hey, we've got a question about this one, we think maybe the answer should be this, and HFMA will take that information and take a look at the question to see how they can change it. So, okay. Let's change that. Okay, we're almost there. So we will probably finish up in about 10-15 minutes. We'll have time for questions and certainly give everybody some time back in their day, as I'm sure many of us are probably doing this during our lunch hour. So in this section, we'll discuss departments and personnel with whom revenue cycle staff and leaders will work with in a patient-centric revenue cycle. We are certainly not in a silo as we work through this. So healthcare providers are faced with an increasingly complex operating environment. Using and optimizing, and that's a key question there, using and optimizing technology provides a competitive edge, right, and decreased costs by streamlining operations, increasing productivity, accessing profitability by health plan and patient type, and providing quality care. You can't just take good technology and keep the same old processes. So anytime you're investing in technology, whether it's an eligibility, an estimation, a prior authorization, a claim scrubber, denial, whatever that technology might be to support your revenue cycle, because we know many times our EMRs don't give us everything that we need. Make sure you change your processes as well. Embrace how you can change what you're doing. I've seen way too many people by technology and keep the same processes and then wonder why that they don't have any changes, right? I didn't get the results that I expected. Well, you're not doing anything different that you did. So that's a thing that we need to make sure that we as organizations embrace changes in technology and best practices. Organizations that do not keep up with information technology will be faced with limitations on their ability to attract and retain not just patients, but staff. And I think we've all heard about the great resignation of 2020, or whatever we're calling it now. And we also know that for many of us in our revenue cycle, right, we're gonna have to do more with less because there are too many options out there. Or you might have been, competing with talent in your own backyard. Well, you're not now, because a lot of RCM positions are going remote and staying remote. And I may live in Florida, but I can go work for an organization in Michigan, right? Because they're going to pay me more and I don't have to go into the office. So we've got to learn how to compete, but also, right, have staff do what staff needs to do, let technology do what it can. The only way we're going to get past these staffing shortages is if we embrace exception-based workflow. So IT is an important component of what we do. Common software applications include, but are not limited to, scheduling, ADTs, pre-bill editing, electronic claim generation, payment tracking, AR management, cash posting, collection transfers. Some EMRs will state that they don't require bolt-ons, pretty much an incorrect statement. Additional bolt-ons are typically electronic eligibility verification, estimation calculators, automated prior authorization, computer-assisted coding, charge integrity, claim scrubbers, automated claim statusing using RPA, denial and appeal support, and analytics. As patients become more comfortable with the internet, they're demanding online access. They expect providers to offer online scheduling, bill payment, and customer chat, to name a few. Collaboration, obviously, with clinical services, although focused on the clinical needs of the patient, right, as they should be, a number of their activities support revenue cycle as well. Some examples include review patient chart and armband to ensure accuracy. We're still using armbands. Obtain consent to specialty surgery. Entering charges accurately and timely, and documenting care. And then collaboration with finance. They're usually responsible for compliance with state and federal reimbursement reporting requirements, but they also provide modeling for contract negotiations and estimate the impact of regulatory changes on the provider's financial performance. So we're all working together to make sure that we maintain the margins of our organizations. So which is not a department that supports and collaborates with the revenue cycle? Clinical services, finance, assisted living, or information technology. And since we just went through this slide, I'm going to presume you all got it right and know that assisted living is a non-acute care residential service, part of the continuum of care for a select group of patients. And it is not a department that collaborates with the revenue cycle. Okay. So let's talk about continuum of care. It's a way of coordinating and linking healthcare resources, facilitating a seamless movement among care settings. It seeks to implement linkages to connect patients who are leaving the acute care settings with post-acute facilities and services. The coordination of care has gained importance as alternative payment models expand to include bundled payments, and we're going to hear a lot more about that in the future. Physician offices provide the order, schedule the service, and obtain authorizations. Post-acute care, they may go to a skilled nursing facility. They may work with a home health agency who may have durable medical equipment or assisted living. And unfortunately, we may need to assist with hospice as well. So that is how we work together to make sure we have a continuum of care to avoid those adverse effects that have patients constantly coming back in to the inpatient through the ED and break that cycle of constantly readmitting, which we now know we may not get reimbursed for if it can be something that can be avoided. So key points, again, what is continuum of care and how do they work together, coordinate and link healthcare services and make sure patients are getting the services they need to avoid those readmissions that we may not get reimbursed for, right? It involves multiple healthcare professionals in multiple settings at multiple levels, which again is the goal to coordinate patients' healthcare so our communities can stay healthy. So which option is not a continuum of care provider? And these are truly questions that are going to be out there. These are sample exams. We can't tell you exactly what's going to be on the exam. It's going to fluctuate. They randomly pick them. But we know continuum of care providers absolutely includes hospice, physician, skilled nursing facility, does not include health care contracting, right? So we may work with the health care from a utilization management perspective, from a prior authorization perspective, appropriate level of care, but they're not a continuum of care provider. Okay, and our last section, some real fun stuff, compliance and HIPAA regulations. So in this section, we're going to talk about the rise in corporate compliance programs, including their complexity and importance. What are the components of the programs? What is the role of the compliance officer? Certainly everybody's aware of HIPAA, right? Then we're going to cover the key risk areas that are perceived to lead to potential fraud and abuse, such as upcoding, inaccurate or incorrect coding, bundling or unbundling of services. We all know there's duplicate billing out there, billing for medically unnecessary services, the waiving of deductibles or co-payments to entice business that would be illegal, and then insufficient documentation. Yeah. Believing that organizations are ultimately in the best position of self-police, the Office of Inspector General, or OIG, developed a model compliance plan in 1997 for labs and then for hospitals in 1998, followed by a dozen other guidance documentations for pretty much every type of healthcare provider and service provider there is, like DME and pharmacy. They cover the key risk areas that are perceived to lead to potential fraud and abuse. And again, as we mentioned, we talked about upcoding, inaccurate or incorrect coding, bundling, unbundling, waiving of deductibles, insufficient documentation. So there are 16 essential elements that are required. Self-reporting, culture that encourages reporting. You must have a compliance officer. You must have an oversight. You must have written procedures, including an employee code of ethics, training, hotline, exercise due diligence with sanctioned individuals, monitoring systems, establish standards and procedures. It must be in writing. It's something that people must be able to access. You must have an effective plan. You must have discretionary authority, independent evaluations, disciplinary measures, and you must have an audit plan, obviously. And if you don't follow the plan, in 2017, the federal justice government recovered $2.6 billion for allegedly providing unnecessary or inadequate care, paid kickbacks to healthcare providers to induce the use of certain goods and services. So Rena's Stark regulations, hopefully, and overcharged for goods and services paid for by Medicare, Medicaid, and other healthcare programs. I don't think they're playing around. So which are the following, and I know we went through that a lot, but again, an example of some of the questions that you're going to have out there. Which of the following are not essential elements of a compliance program? So a couple of things I'm going to point out to you on these questions. You may have multi-choice, right? It's not going to be an absolute. So you may get out into the CRCR and it may say choose all that apply. So this is a good example of a question would be choose all of apply. So the reasonable methods to achieve compliance is absolutely included in it. Establish compliance standards and procedures is included in it. We referenced discretionary authority over what we do with employees, right? it is not automatic dismissal, right? That is not going to be, you're not required to absolutely dismiss any employee excluded for participating in the federal healthcare program. So the wording is very, very different. You must have oversight by a high level personnel, right? And it is not somebody that the designation of a compliance officer should not be employed within the billing department. It's usually somebody very independent, may not even report to the CEO. It may report directly to the board. So they must have that compliance officer must be extremely independent and not reporting to a CEO. They've got to be able to do their job should there be a compliance issue. So yes, you have to have a compliance officer. They're not going to be employed in the billing department. Okay. So the code of conduct is believed to be the backbone of the organization's compliance program. The code of conduct, if implemented effectively and enhanced as needed, can reduce weaknesses by helping employees and agents understand their roles and responsibilities while focusing an environment where concerns and questions are raised without fear of retaliation or retribution. It is a living, breathing embodiment of the program. As I mentioned, in the most effective programs, the Chief Compliance Officer, or CCO, typically reports directly to the board directors or the trustees so they can maintain independence. So the OIG was created to protect the integrity of HHS, our health hospitals and systems. It identifies and holds accountable those who do not meet program requirements. It publishes an annual statement of work, but is now updated as needed on a monthly basis. Some examples of work plans include initiatives related to prescription opioid drug abuse. We know we hear it all the time. Medicare payments made outside of hospice. There are some very high rules on that. Denials and appeals in Medicare Part D program. And some well-known names that were issued corporate integrity agreements included Tenant, National Health Laboratories, and U of Penn. So even the largest organizations out there are not, are not complying with and have those codes of conducts and those CCOs and really managing what's going on in their organization. So it can happen. So, well, I think we have all heard about HIPAA, the Health Insurance Portability and Accountability Act. The goals of HIPAA are pretty clear. Protection of patient information, restriction of access to PHI, and ensuring that BAAs are in place with business partners before the sharing of any PHI data, right? And then certainly give patients access to their health files, facilitate electronic exchange of medical information. That all happened, unfortunately, due to Hurricane Katrina, where we realized that we weren't sharing EMRs, and that became a big issue. So that's another component of what it's trying to do. So certainly HIPAA included what we call the transaction step. I usually state that there is no standardization in the ANSI transaction step, but that rule was intended to do that. The problem, however, is that the requirements for most of the transaction sense is very loose, right? It's not absolute. You don't have to reply in a certain service type code. You don't have to use certain CARC and RARC codes on the back end of the billing. You don't have to provide every segment and loop that's available in the code set. So I always say there's just no standardization in it. There's honestly no enforcement of any standardization as well. So the transaction code sets, right? The final rule did adopt standards for 8 electronic transactions and code sets, again, that are to be used throughout the healthcare industry. And most payers and plans are using these. Some, again, not standardized and being minimal in their requirements to do that. So, but we're all familiar with 837. That is the healthcare claim transaction. It'll be 837I, 837P. 834 is the enrollment and disenrollment in a health plan. Standardly, we see 270, 271, which is the healthcare benefit eligibility inquiry response. 835 is our electronic payment, our ERA. 820 is related to health plan premium payments. 276, 277 is our health plan status request and response. Again, that's even more ripe with no standardization and not actionable information. 277, 278 is our referral certification and authorization, and also supports notice of inpatient admission. And again, I got claim twice because we love it so much. Claim is our 837. Again, both I for institutional, P for professional. So on May 31st, 2002, HHS released its final rule, Health Insurance Reform, Standard Unique Employer Identifier. The use of a unique employer identifier is required under HIPAA. The rule adopts the employer identification number assigned by the IRS to be used in standard transactions to identify the employer of an individual described in a transaction, such as the transmission of enrollment or disenrollment information to a health plan. Any business required to furnish a taxpayer identification number, meaning that wages are paid to one or more employees, must use an employee ID number, EIN, as its taxpayer identifying number. The compliance date for the implementation for most covered entities was way long ago, July 30th, 2004, August 1st, 2005 for small health plans. So it's been in play for a while. We should all know what an NPI is, or a National Provider Identifier. The NPI is a unique identification number for covered healthcare providers. Covered healthcare providers in all health plans and healthcare clearinghouses will use the NPIs in the administrative and financial transactions adopted under HIPAA. The NPI is a 10-position intelligence-free numeric identifier. This means that the numbers do not carry any other information about healthcare providers, such as the state in which they live or their medical specialty. Beginning in 2007, the NPI needed to be used in lieu of legacy provider identifiers in the HIPAA standard transactions. So privacy of health information, you must provide training to all staff within the organizations on its policies and procedures governing HIPAA. Define protected health information and access thereto by individuals and business associates. Ensure that training is based on the job responsibilities of staff who handle protected information. Ensure that a privacy officer is hired and designated, and ensure that a contact person is hired and designated to handle questions or concerns regarding the protection of PHI. HIPAA Title II required the Department of Health and Human Services to establish a national standards for the security of health information, electronic healthcare information. The final rule adopting HIPAA standards for security was published in the Federal Register, again, quite some time ago, back in 2003. This final rule specifies a series of administrative, technical, and physical security procedures for covered entities to use to ensure the confidentiality of electronic protected health information. The standards are either delineated into either required or addressable implementation specifics. Again, as I said, no standardization in standards. So the key points, hopefully you're going to come away with when you complete this section, is that each healthcare organization has a compliance program. Within the revenue cycle, staff need to understand the importance of compliance with federal and state program requirements. Medicare program issues related to the 3-day window, 1-day window, Medicare secondary payer, and advanced beneficiary notices, as well as CCI rules, are keys to compliant claim processing. And we'll get more into that in great detail. HIPAA requirements for privacy and security, as well as the opportunities presented through the electronic transaction sets, also impacts revenue cycle operations. Okay, so a couple of questions here. Again, an example of what you might see out there when you go through the course and when you get to the exam. Identify which option is not a work plan task mentioned in this course. So I know we did talk about denials and appeals in Medicare Part D. We talked about Medicare payments made outside of the hospital benefit. It does also include, but I didn't mention it during our talking, denials and appeals in Medicare Part C, which is your Medicare Advantage. It does not include reconciliation of outlier payments. Okay. So with that, I'm going to stop. I'm going to end the slideshow and see if there are any questions in the chat. I'm also going to stop sharing. So I'm not seeing any questions in the chat right now. One, if you want to put it in the chat, I'm happy to answer it that way. Or I am happy certainly to take questions live if you want to take yourself off mute and you've got a question, whether it's a technical question about how to take the exam. Well, while we all look at Natasha's pretty picture, which I think is what you might not seen. I'm just seeing Natasha now. But if you have any questions, please come off mute or again, put it in the chat. Okay. All right. With that, I'll give you back a few minutes of time. Again, this will be posted onto the YouTube channel, although there are other ones already there. And again, on the website is the same material we went over today, but it's already posted under the fall 21 materials that we did. Sign up for CRCR. Taking this course will not get you to pass. All right, you have to do both, right? Whether you do simultaneously, which is what we highly recommend and has been the most successful, or you do a big study session right before you take the exam. Okay. So hopefully, again, people are welcome to join. If they missed this session, again, they can catch up on it. If you know anybody else that was not aware that these were being offered, please highly encourage them to sign up for the series and get signed up for the CRCR so they can get that certification. So give you all a couple of days and hope you have a good rest of your week. And we look forward to talking to you next week.
Thank you.
Thank you.
Take care, guys.
Thank you.